Treace Medical is the company who patented the Lapiplasty procedure and manufactures its instruments and implants. Our goal here tonight is to provide you with quality information because we know that making a surgical decision is something that you're not taking lightly. We actually applaud you for getting online and empowering yourselves with the information to make the best, most informed decision you can make. I'll quickly get some housekeeping items out of the way so we can get right into the presentation by our surgeon speaker, Dr. William DeCarbo of Pittsburgh, Pennsylvania. First of all, you are listening to the webinar on mute, but you can ask questions throughout by clicking on the Questions tab in your control bar and typing them in. We'll be answering questions sprinkled throughout the presentation and at its end. And if you're a note taker or if you inadvertently missed something, we'll be offering this presentation as an archive link to refer back to. So look for that follow-up from us in just a couple of days. And lastly, I know that you're going to enjoy our speaker, Dr. William DeCarbo, but if you're attending outside the Pittsburgh metropolitan area, you can find locally trained Lapiplasty surgeons to consult with in your own area by visiting our patient website, alignmytoe.com. There's a prominent Find a Doctor button at the top of the home page, and it's searchable by zip code. Okay. With all of that out of the way, I'd like to introduce tonight's speaker, Dr. William DeCarbo. Dr. DeCarbo is a paid consultant of Treace Medical. His qualifications and experience are extensive, and his practice is a Lapiplasty Center of Excellence. Dr. DeCarbo is board certified in foot and ankle surgery, and he practices at St. Clair Hospital, serving the greater Pittsburgh, Pennsylvania area. Dr. DeCarbo completed his medical school at the Ohio College of Podiatric Medicine in Cleveland and a podiatric surgical residency at Grant Medical Center in Columbus, Ohio, where he also served as chief resident. Then he went on to complete his foot and ankle fellowship at the prestigious Orthopedic Foot and Ankle Center in Columbus, Ohio as well. Dr. DeCarbo lectures at the state, national, and international level, and his research is published. He serves as a review editor for the Journal of Foot and Ankle Surgery, as well as the Foot and Ankle Specialist. And he's a member of the American College of Foot and Ankle Surgeons. We appreciate Dr. DeCarbo volunteering his time tonight. I'll return later to moderate a question and answer segment at the end, but now I turn it over to Dr. DeCarbo.
Thank you, Kara, and thank you all for joining tonight. You know, I'm from Pittsburgh and there's Monday Night Football, so we're all making sacrifices to be here for a great cause. So I appreciate everyone being on this call. We're going to go through this procedure tonight. It's very exciting. I'll tell you my thoughts on this as we go and towards the end. But this is an affliction of a bunion that affects many people, and we're hoping to offer you a solution that helps. When we look at the background of the device, Lapiplasty itself and 3D bunion correction, it's important to point out that this is FDA cleared device. This is not an investigational device. It's been FDA cleared since 2015 and is a patented procedure. As Kara alluded to, it's manufactured by Treace Medical Concepts, and it requires specific training for surgeons to use it. So you have to have a training and be approved in order to do it. There's thousands of surgeons trained around the country, and there's thousands of patients that have been treated. And also was mentioned, you can find these trained doctors at alignmytoe.com/doctor. The procedure is covered by most insurances. That's a common question. You'd have to check with your provider if there's any variances, but the procedure is covered. When we talk about Lapiplasty or any surgery in general, but for this specific case, Lapiplasty, this is a medical treatment and individual results may vary. There are potential risks and recoveries that take place. Some of the potential risks include, but are not limited to, infection, discomfort from the presence of the implant, loosening of the implant, loss of correction with non or malunion. And what non or malunion basically means is either the bone segment doesn't heal, which would be called a non-union, or the bone segment would heal in a undesired alignment, which would be a malunion. And if either of these would happen to occur, additional procedures may be needed to correct that. and only a surgeon trained in Lapiplasty can decide if that's right for you. As we mentioned, Lapiplasty is a 3D correction procedure covered by one or more US patents, and the information could be found at alignmytoe.com. When we look at bunion pain and how it affects your quality of life, we want to offer a new treatment option for that and for the patient. Bunions, which the technical term is called hallux valgus, it's often asked, how do I know if I have one? And you can see the picture on the left, the normal foot, and the picture on the right with a bump or a prominence or a protrusion on the inside of the foot. And that there is the bunion, and you can see it depicted by the circle. Bunions are more than just a bump, but we'll get into that as we go further into this lecture. But as you look at the pictures of these right foot or feet, if you will, starting with the left to right, you can see there's different severities of bunion over time. So they're mild, moderate, or severe, and these are progressive deformities, and we'll talk about that as well. Why do bunions hurt is because your entire body weight rests on the bunion or on that big toe joint with each step. And you can imagine that if there's an abnormal alignment, this just exacerbates the abnormal pressure or force through the foot, and this causes pain. Some of the common symptoms that patients experience with bunions are pain and swelling, pressure or numbness. The reason for that is typically when you have the deformity or the prominence of the medial or the inside of the big toe, it presses on the shoes. There's a sensory nerve or a superficial nerve right in that area, and that's where you get that numbness sensation. And obviously that can all be exacerbated as the toes are crowded in a shoe, or if you're standing for long periods of time, again, putting excessive weight on the abnormal forefoot. What causes a bunion? They are genetic predisposition. So a lot of people will come in and say, well, my mom, had bunions, or my grandmother had bunions, this sort of thing. And it's a biomechanical imbalance. There's muscles and ligaments and tendons and whatnot in the foot. And over time, there could be a mechanical disadvantage of these muscles with an unstable midfoot joint, and the bunion starts to progress over time. But typically, this is a genetic predisposition. There's a misnomer, if you will, about footwear, and does footwear actually cause, shoes or whatnot, cause a bunion? And the reality is the footwear actually aggravates or accelerates the condition, but it's probably not the cause, period. Or sorry. Certain occupations may aggravate the condition. So anybody who is up on their feet for long periods of time or have a very active job where they're on their feet, they can be more painful. And again, I tell my patients daily, if the average person walks anywhere from 4,000 to 5,000 steps a day, if you have a high intensity job, you may be around 10 to 15,000 steps a day. And that obviously puts more stress and load through the deformity of the big toe, and that causes more pain. Footwear is also a major contributing factor to painful bunions. And again, it comes down to the space in the toe box or the front part of the shoe. If you have a deformity where you have that large eminence or prominence on the inside of the foot and you're jamming that into a shoe, so to speak, that's going to exacerbate the pain. So shoes can accelerate the pain and patients coming in and seeking treatment. It's a common question, who is a candidate for bunions treatment or surgical correction of bunion? And it's important to know that the FDA has cleared this procedure for patients 12 years old or above. So really the age limit after 12 is unlimited, and it's based upon the individual patient. Is their bunion so severe that it can't be treated? And the answer is technically no. And what I mean by technically is, in some bunions, if there's degeneration of the big toe joint and not just an instability of the midfoot joint, and we'll talk about that as we get closer, and that will become self-evident. I'll show you a picture. Sometimes Lapiplasty may not be a choice if it's severe where there's arthritis of the big toe joint. But as a general statement, there's no bunion that can't be treated surgically. What if you had bunion surgery in the past? And this is something that's common. There's a high recurrence rate with our current treatment for bunions, not the 3D bunion. And we'll talk about that again further on in this lecture. But there are revision surgery that we can do with the Lapiplasty, even if you had previous bunion surgery in the past. Bunions, as I mentioned, are a progressive deformity. They do not go away on their own. In fact, over time, they get worse. And the saying is, if you walk through a nursery, you don't see bunions and hammertoes. But if you walk through a nursing home, there's a plethora of bunions and hammertoes. And it's just an indication that this is a deformity that progresses over time and gets worse as you progress through life and whatnot. What happens if you don't treat your bunion is a common question, and the bunion will get worse. It's progressive, and then there's arthritis that develops specifically in the big toe joint, and that arthritis becomes extremely painful. The toes or the lesser toes can start to hammer, what is known as a hammer toe, and if they get severe enough, they can cross over, and we've all probably seen pictures or know somebody in our lives that toes overlap because of the deformity. You can get spurring of bones from the arthritis and overall pain in the ball of the foot. And the reason for this is if the big toe is not aligned properly, as you walk, the force through the foot from the ground is not transferred or dissipated properly. And what ends up happening is that force goes on to the ball of the foot, or what we call the lesser metatarsals, and patients will get pain under the second or third toe. And a lot of times that pain under the second or third toe is actually coming from the bunion or the deformity of the first, because it's not taking its proper weight with ambulation. It's a common question, are there conservative treatments for bunion, or something that you can hold off surgery with? And the answer is there are braces or slings that can be used that, if your deformity is still flexible, will align the toe, but it does not address the root cause or fix the problem, at all. It may give you some relief if you can straighten this, but over time you can wear that straightener indefinitely, but it's not going to change the anatomy or structure of the foot. And so, as I'm alluding to, that's designed really just to keep you comfortable, but won't fix the problem. And there is multiple over-the-counter devices such as toe spacers, pads, splints, inserts, or orthotics that kind of go in the shoe. All of that is designed to offload the pressure, support the deformity, try to realign the deformity externally, and alleviate the pressure on the inside bump. This is an important slide because this is a cartoon illustration of an x-ray or the bone of the foot. And there's a common misconception that the bunion is just an overgrowth of bone that can simply be shaved off. And that's actually inaccurate. The bunion is actual prominence from the head of what we call the first metatarsal. That's that long bone behind the toe. And I'm just going to show you with my pointer. This bone here is the first metatarsal, and then this is the toe bone, these two bones here. And when patients have a bunion, this is not an abnormal growth or bump. This is actually this joint subluxing. And so the prominence that you feel is what we call the medial head of the first metatarsal. And then, as you can see from this illustration, the root cause is this unstable joint in the midfoot. That makes bunions a complex deformity. These are three-dimensional. The bunions are caused by the unstable joint in the midfoot called the first tarsal metatarsal joint. And what that does is allows this bone or the metatarsal to drift out of alignment. And that's the common bunion that we speak of. And that's the common foot abnormality that you see or patients come in with and notice or have pain with. This is what bunions look like on an x-ray. The left image is a normal foot, and you can see the alignment of the toe and the bone behind it called the first metatarsal, and also those two little circle bones are called sesamoids. Everyone has sesamoids. Sesamoids are like kneecaps. They give the muscle a mechanical advantage as you walk. It helps pull the big toe down. And as you can see in a normal foot, those sesamoids should be directly under the head of that bone called the first metatarsal. In a bunion, as you see to the right, there's an abnormality in alignment of that first metatarsal, and the toe starts to drift towards the second toe. The big toe starts to drift towards the second toe, and you can see the prominence of that metatarsal head. Of note, you can see those sesamoids, those two little bones, not being underneath the head of the bone, therefore they can't distribute weight as you walk appropriately. You can just see that with the circle there. In 87% of bunions, there's a malalignment on all three dimensions, or what we call all three cardinal planes of the body. And the planes of the body are the transverse plane, something called the sagittal plane, and then the frontal plane. And what Lapiplasty or the 3D bunion allows or does is correct all three planes at once to restore normal anatomy to the foot. The problem with this, as we are stating, is there's an unstable foundation. So just like the Leaning Tower of Pisa, I always like that illustration in this example, the big toe starts to lean, and it starts to lean medially where the bump comes on the inside of the foot. And that's what you're seeing here by this cartoon drawing of the bunion deformity or abnormal alignment. The second thing that happens, and that first image was what we call the transverse plane. The second thing that happens is the bone, because it's unstable, actually starts to elevate up off the ground. And then this is what we call the sagittal plane. And this is one of the reasons where you get transfer pain underneath the second or third toe when patients come in, as I said a couple of slides ago, and said they have pain on the ball of their foot. Well, because that joint is unstable, that first metatarsal bone and toe does not function properly. And so as it elevates, it creates an overload to what we call the lesser metatarsals, specifically the second and third toe or metatarsal bones. And the third component of this, and a very important and often overlooked component, is the rotation. The bone of the first metatarsal is rotated, and just like a car, as you can see from the picture, if the alignment is off, you get abnormal wear and you get pain. And these three components are what we consider the cardinal planes of the deformity and cardinal planes of the body. And Lapiplasty addresses all these in order to fix the deformity. This is in direct contrast to what we call a traditional or two-dimensional, 2D bunion surgery, also called an osteotomy. Osteotomy means where we cut the bone and move it to another position and then put in plates or screws in order to hold it. And you can see a picture of that to the right. We'll go into that a little more involved here as we go through the lecture. In a 2D correction or an osteotomy surgery where they cut the bone, it's made up primarily of two components, and staying on the Leaning Tower of Pisa theme, the first component of a two-dimensional correction for a three-dimensional problem is to shave the bump. So as you can see, that bump, which was actually the normal head of the first metatarsal, it was just subluxed out of the joint, is shaved off. And again, this does not address the unstable joint. And then the bone is cut and shifted over in order to make the toe appear that this is corrected. And again, as you can see from the illustration, and it's important to continue to point out, this does not correct or address the root of the problem. The root of the problem is the unstable midfoot joint called the first tarsal metatarsal joint, and the big arrow shows that. Now the circle and the small arrow shows what's happening, and then you have the cartoon of the Leaning Tower of Pisa showing that's how we would fix that lean or that deformity. We would cut a portion of it and slide it over. So the bump is gone. However, when we look at the x-rays, the bone that was straight and just out of alignment is now crooked. So in this two-dimensional procedure, or the traditional bunion correction, the way it's typically been done for years, we actually create a deformity that wasn't there by cutting the bone and making it crooked in order to make the toe clinically look better. So this picture kind of shows that. So it looks okay on the outside where the toe is somewhat aligned. But the problem is on the x-ray, we still have the unstable joint that caused the problem. It's not addressed. And you have a crooked bone now that was once straight in order to try to make the appearance of a correction. So when we look at two-dimensional bunion surgery versus three-dimensional bunion surgery, there's 12 times higher likelihood of recurrence with a two-dimensional correction, meaning if all three dimensions, the transverse, frontal, and sagittal plane, are not addressed, there's a 12-time higher chance of recurrence. When we look at multiple papers, 1 in 3 patients that had traditional 2D or osteotomy bunion surgery are dissatisfied. And when you look through all the published papers on bunion correction, there's upwards of 70% of patients have recurrence over time. And again, this is because the deformity is a triplane or three-dimensional deformity, and only 2 dimensions are typically corrected in the traditional approach. So Lapiplasty is a three-dimensional bunion correction that fixes it right the first time, and that's what we'll go into and discuss as we go forward. This three-dimensional correction, you can see an x-ray of that, and you can see, and we'll talk about this in more depth, but you can see just by that x-ray picture, the bone is just put back into alignment and then held together by plates and screws. We did not or do not cut the bone and create a new deformity. How it works, the entire bone is returned to its normal three-dimensional alignment, and this restores normal anatomy, and the straight toe is then rotated back into position. And you can see the cartoon of the Leaning Tower of Pisa. Instead of cutting that tower and shifting it over where the base is still leaning, the entire tower is now straight and corrected. This is in the joint, the first tarsal-metatarsal joint is then permanently secured in order to not have a recurrence and in order to have that joint fused or healed to maintain long-term outcome. This is done by 2 titanium plates. These are patented plates that permanently secure the root cause of the bunion to decrease recurrence. This picture here of the x-rays is just the bunion on the left before surgery, and then again you can see the correction on the right with the three-dimensional correction and Lapiplasty with the plates in the body stabilizing the joint. This is in direct contrast to the left-hand picture, which is the two-dimensional correction that cuts the bone and shifts it over. And as you can see, the bone is now crooked where it was straight, and the unstable joint, this first tarsal-metatarsal joint, was never corrected or never addressed. There's also another surgical option that you may hear called MIS, or minimally invasive surgery. And what this does is, again, cuts the metatarsal and shifts it. And you can see the screw and the pin that holds that. This radiograph shows a traditional lapidus. The traditional lapidus, again, focused on a two-dimensional fix where the the first metatarsal or toe would try to be reduced in what we call the transverse plane, and then plate and screws put over top of that joint to try to hold it in alignment. And you can see that there's still an abnormal position of that bone, but that is what would be considered an acceptable result. And compare that directly to the picture to the right of the Lapiplasty, where if we took the plates and screws out of that image, the image looks like a normal foot. So the Lapiplasty bunion correction restores the anatomy back to its anatomic position. And again, you can see that depicted here, where you can see on the left the normal foot versus the Lapiplasty. And again, the only difference is really the plates and screws that you see within that area. Otherwise, there would be no difference. We're not creating a new deformity. The metatarsal phalangeal joint is still free to move. This surgery is done where we try to do minimum to no work at that joint, so the native tissues remain untouched. And then again, you can see the stability through the unstable joint, or the root cause of the problem, called the tarsal metatarsal joint, shown there as TMT. And this joint is now stable because not only is it fused, but you have this locking plate technology that holds it in this position. So Lapiplasty 3D correction, it fixes the root of the problem to prevent recurrence. It's a three-dimensional correction to get you back to anatomic. The procedure allows you back up on your feet almost immediately, if not immediately, in a walking boot with minimal time off work, and we'll discuss that. And it permanently secures the unstable joint with the plates and screws as we've depicted. Lapiplasty is something that there are thousands of cases that have been done in the United States, and we actually have 10 published clinical articles or clinical papers. What this means are there's research done on this specific procedure, and then these patients or these papers are submitted to medical journals under the scrutiny of peer review. And we have 10 of these papers published so far, with others in what we call the queue, getting ready to be published. So this is a procedure that is having great results and medically accepted in the literature. There's a 97% success rate when we look at studies at 13 months or longer, maintaining this three-dimensional correction. So 97% of these patients are maintaining this correction long recurrence rate. This is a clinical picture of a foot before surgery on the left, and you can see that medial eminence, medial prominence or bump that is known as the bunion, and you can see the toe drifting over to the second toe. And then this is a 12-week post-op procedure that the Lapiplasty was performed, and you can see the bump is gone, and you can see the alignment and the straightness of the toe. One of the things to look for is the big toe nail, and you can see the picture before surgery is tilted on its side, where the after surgery it's straight up and down. This is just another image showing surgery pre-op, and then what we call post-op, again at 12 weeks. And you can see the toe is straight and aligned, and you can see how the incision heals. And this is just another picture of the same. This is 16 weeks post-operatively, and you can see the alignment of the nail, the big toe. The big toe and the second aren't touching, so it's not overcrowding. And again, the bump is eliminated. This allows patients to get back to their normal activities that you enjoy, and this could be walking, hiking, running. You know, we advocate patients getting back to their normal activity. Once the toe is aligned and healed, patients can start getting back to this very rapidly, and we'll discuss that as we get through this a little further. I just want to talk quickly about the plate technology. This is patented, this two-plate system. The plates are titanium, and you can see a picture. Those are actual what the plates and screws look like in the top right-hand corner. The plates are put on at a 90-degree angle to each other, so it creates a buttress of the joint on multiple planes. And this allows for stability, and this also allows for early weight bearing because of this unique construct in this plating system. And this is how we're getting patients up and walking within 3 to 4 days, if not immediate post-op, versus a traditional procedure in Lapidus. Patients at times were non-weight bearing upwards of 6 weeks. These are low profile plates, as you can see, and 2 plates are better than 1. This secures the long-term fixation. It's a common question about recovery and what can I expect? And within days, patients are normally put into some sort of weight-bearing device or offloading device on their foot, typically a boot. Could be a surgical shoe, but it's typically a boot like you see depicted here to the left and the picture immediate to the right of that. This boot is typically worn for 4 to 6 weeks, so it's immediate weight bearing in the boot for this 4 to 6 week time period. At 6 weeks, and rarely upwards of 8, but usually at 6 weeks, we get you back into a regular shoe. And again, I just want to point out, because it's an important point of distinction, with traditional 2-dimensional Lapidus procedure or bunion correction, sometimes patients are non-weight bearing upwards of 6 weeks. We have patients with this procedure back in a shoe at 6 weeks. We recommend a return to full activity such as impact sport, running, jumping, and whatnot at 4 to 6 months. And that's where patients return to these activities. And again, this is patient dependent, but an overall blanket statement. This is our goal and where most patients fit in. In the first 5 to 10 days, what can you expect? You can see a picture of a surgical dressing on the bottom and the patient top right in a boot walking. So patients do have pain, obviously, with surgery. Through that time, you do have pain medicine to help keep you comfortable as you get through that. You are wearing the boot. The dressing is on the foot to be kept clean and dry. It's recommended to elevate and ice the foot, just helps with swelling. And as the swelling can be controlled in those first 5 days, it will diminish the amount of pain you have long term. It's also recommended surgeon preference about aspirin, and this just helps prevent any blood clots or whatnot after the surgical op. At the first post-operative visit is kind of the big reveal. You know, patients are excited to see, you know, what their foot looks like. The dressing is removed. And as happy as people are, the foot is swollen from the trauma of surgery. So most patients are very pleased and satisfied. And the majority of the time I have to tell them this will just continue to get better over the next 3, 6, 9, and 12 months. Because as all that swelling dissipates, the foot is actually going to look better and get smaller, so to speak. And I show patients the x-ray so they can see the alignment and they understand, because on the x-ray you can see that soft tissue swelling, or what we call the soft tissue envelope. At this visit, patients are put in a boot walker or a surgical shoe, but typically a boot walker is used and recommended, and they're immediately weight bearing. A lot of times the foot is bruised and swollen from surgery, and again, rest and ice and elevation help kind of dissipate that over time, and patients can go back to normal bathing at this point and non-impact exercises. At around 2.5 weeks, you're starting to feel better. The swelling's coming out. The sutures were removed at this point or a little sooner. At times you can get sort of stabbing or shooting pain, and this is from the swelling. As the foot swells from the surgery and as you start walking on it, it presses on the superficial nerves of the foot, and you can get abnormal sensation. And again, this dissipates rapidly as you get further from the surgery, hastens this process. And again, you can continue normal bathing and exercising as you see fit. At about 6 weeks is when we want you to get back into a lace-up tennis shoe or a walking shoe. Patients always ask about driving. At this point, we can start to get back into driving if it's your right foot. However, a lot of patients at around 3 weeks, if they feel up to it and if their foot allows them, they can actually take the boot off and drive at that point. Again, this is surgeon preference and this is patient dependent, but typically the recommendation is once you're in a shoe, you can go back to start to driving. You can stand in a shower barefoot at this 6 weeks, and really you could do that almost immediately at that first post-operative visit. If you put the majority of weight on your heel and not on the front part of that foot, you certainly can stand in the shower. We're going to continue to elevate, rest, and ice. At this point, 6 weeks, you can discontinue the aspirin. And the reason for this is now you're more mobile in a shoe, and you can start to get to light impact, such as treadmill, as you see to the right. Again, still no jumping or return to sport at this point, but you can certainly start light impact exercise. At around 12 weeks or 3 months, this kind of switches into the second phase. This is pretty far along where patients can get back to increased activity, swimming, high heel shoes, as you see to the top left, or even hiking or walking for leisure. At this point, you can swim or soak your foot. And again, we recommend that you continue to elevate when possible, ice and rest. And again, that all helps with that swelling that takes time to fully dissipate. At 4 months, patients start to ask if we're done. They're getting back to feeling great. And at this point, we start to release them to all activities, including jumping, running, and return to sport. Also, at that point, they could walk barefoot or in a flip-flop at this time and really go back to whatever feels good. And I tell my patients, you let your body be your guide. Whatever feels good at that point, you can do. The foot will still swell at times because it's healing, and the body heals upwards of 1 year, even though you're back walking immediately in a shoe at 6 weeks, back to sport and full activity at 3 to 6 months. The body will continue to heal this for 1 year. Compression socks control some of that swelling, and that's a good idea. Sometimes patients could even be discharged at this point. I tend to follow my patients upwards of a year for 2 reasons. One, I want to make sure they're doing well, and 2, we want to prove this concept over time. So as we follow patients and collect this data, and as you saw from previous slides, this is a heavy researched and monitored procedure by us. We're making sure that everything we're doing is not only working, but we're having long-term success and results. And then we're publishing those results in medical journals for other surgeons to read, and that builds off their practice and what they're doing with it in the future. Recovery expectations. A common question is, when can I return to work? And the simple answer is that depends, and it frankly depends on what you do. If you have a sedentary job or a work from home or a low demand as far as walking job, you can return almost immediately. I tell patients 10 days to 2 weeks. You want to take off. You want to respect the trauma of surgery. We're still going through tissue and realigning the bone and putting plates and screws, and the body heals with swelling or inflammation. And the more you can rest and ice and elevate within those first few weeks, the better off you do long term. So I tell patients, for the most part, 10 days, 2 weeks. If you work from home, immediately. If you have a pure sedentary job or desk job, again, that's patient preference. When will I be able to drive if it's my right foot? We kind of talked about this. It's important, though, to mention again, the recommendation is once you're out of any surgical device, such as the boot, and that happens at 6 weeks. However, patient dependent and how the patient feels and their comfort level and pain level, if they can depress the gas pedal and brake in a shoe, they can sometimes drive around the 2 or 3 week point. And then whenever they get to where they're going, you'd put the boot back on. We still don't want you walking in a regular shoe or outside the boot for the first 6 weeks. Another very common question, is it possible to have both feet treated at once? And frankly, that's surgeon preference, and it's not recommended. And the reason it's not recommended is, although the complication rate with any surgery and also with Lapiplasty is extremely low, the complication rate isn't zero. And if we had both feet done at once, we want you up walking immediately. But if one foot was painful, or if we had a little setback where it's going to take a week or 2 longer to reach our milestones, we don't want to hold you back. So it's better to have a good leg to stand on, no pun intended, and not do both feet at once. The patients tend to do better. Their recovery tends to be faster. And then the next foot could be cycled in at anywhere from 3 to 6 months. And again, that is patient and surgeon dependent. As a reminder, I just want to reiterate, this is a medical treatment and individual results vary from patient to patient, or may vary. There are potential risks, and the recovery simply takes time. And as I stated previously, even though you're walking immediately in a shoe at 6 weeks, return to sport 3 to 6 months, your body will heal this surgery, or any surgery, upwards of 1 year. The potential risks include, but are not limited to, infection, discomfort from the presence of the implant, loosening of the implant, and loss of correction. And again, this could be caused by a male or non-union, and we discussed that previously, but a non-union is where that bone segment doesn't heal, and a male union is where it heals, but in a undesired position. If either of those two happen, the male union or non-union, you may require, or the patient may require, additional treatment. The Lapiplasty information or surgeons to find are on the website, and these are specifically trained surgeons for Lapiplasty. And that's at alignmytoe.com/doctor. And remember, it's important point at the bottom of the red arrow, only Lapiplasty, which is a registered trademark and a patented procedure, is Lapiplasty. So if you're looking to have bunion correction and you're interested in Lapiplasty, it's important that the surgeon or provider is doing Lapiplasty and not just saying that they correct this. There's only one available on the market system that does 3-dimensional correction, and again, that is Lapiplasty. At this point, I'm going to open this up to any questions, and then after questions, we just have 2 more slides just to kind of surmise what we've talked about here tonight. So I will allow Kara to intervene on this and see if there's any questions.
Yeah, well, thanks very much for your time, Dr. DeCarbo. We do have some questions coming in. We do have some good audience participation happening behind the scenes, so we encourage people to stick with us. We'll do our best to answer most, if not all, your questions. And as a reminder, if you have questions that you have not already typed in, you can do so by clicking on the Questions tab in your control bar and typing them to us. Now, one question that comes in very frequently, and I'll go ahead and just field this one real quickly before I turn them over to you, Dr. DeCarbo. We do get a lot of questions. Is the Lapiplasty procedure covered by insurance and or Medicare? And the answer is yes. When the procedure is deemed medically necessary, insurance and Medicare typically cover bunionectomy and joint fusion procedures that utilize the Lapiplasty system. If your doctor determines that the Lapiplasty is right for you, then he or she will reach out to your insurer and determine your specific level of coverage. So with that, I have some questions for you. One of the first questions is, will this work for a 77-year-old female?
So that is a great question. And the simple answer is yes, as long as there is not degeneration of the big toe joint. The big toe joint, as you recall from the lecture, is the joint, I'm pointing with my arrow, where the perceived bump is. Where the Lapiplasty procedure is performed is at the unstable midfoot joint, where the arrow is showing that on this picture on the top of the lecture, at the tarsal metatarsal joint. The reason that is if there's degeneration of this big toe joint, what's called the metatarsal phalangeal joint, the procedure accounts for the bone being rotated back into alignment on the frontal, transverse, and sagittal plane, which is all three cardinal planes. And if we rotate that bone back, but this joint, the big toe joint, doesn't have cartilage, a lot of times the correction is inadequate, and a lot of times patients will continue to have pain. So age is really not a determinant as to whether or not you're a candidate for Lapiplasty. It really has to do with arthritis of the big toe, and that can only be assessed clinically and radiographically. So a patient would have to come into the office and be seen and then have that open discussion.
Well, conversely, someone else is looking for their 16-year-old daughter. Could Lapiplasty work for someone of that age range?
So that's a great question, and the answer is yes. And at 16 years old, depending on radiographs, a lot of times, most of the time, especially in females, the growth plates are closed. So this procedure fuses the joint, and this is something that can be done in 16-year-olds and frankly commonly is. Again, you would need radiographic evaluation and clinical evaluation to go over that for that patient specifically. But yes, 16-year-old patients commonly get bunion corrections, specifically Lapiplasty.
Okay, so we have some questions from people who have bunions on both feet. How long would they have to wait if they did one foot at a time?
So that's a great question. That is patient and surgeon dependent, but typically it's anywhere from 3 to 6 months. So once you are back in a shoe and back to relatively normal weight bearing, then we can cycle in the other foot. And the reason for this, even though you're immediate weight bearing and then protected weight bearing upwards of 6 weeks in a surgical boot, you're still putting pressure, more pressure than normal, on the non-operative foot. So even though the boot is offloading the operative foot, it's still by human nature, you compensate and you put a little more weight on the other side. So we want the surgical side completely healed, back in a shoe, ready to take all the force of the pressure and weight, and then recycle the other foot in. And again, that's anywhere from 3 to 6 months.
All right, well, let's talk a little bit about this boot. I can tell some people are dreading the boot. So is there a certain type that you are assigned? Is there a tall boot versus a short boot that you have to wear? And do you have recommendations on how do you sleep? Do you sleep with it? Can you ever take the boot off during your healing period?
So great question. And before I answer about the boot, I just want to talk about a point of reference. So typically before Lapiplasty, patients would be in a cast upwards of 4 to 6 weeks, non-weight bearing. And then they would be put in this boot for another 3 to 4 weeks, again, surgeon patient dependent, and then around 2.5 months or so put into a shoe. What this procedure allows is immediate weight bearing. So you go into the boot after the first post-operative visit, and some surgeons put patients in the boot immediately post-op where they're allowed to weight bear. The boot is allowed to come off for sleeping, and the boot after the first surgical dressing change and sutures are removed is allowed to come off for bathing. That typically happens within the first 10 to 14 days. There is a difference of boot size. These are walking boots, or what's commonly called fracture boots. There's a short boot that goes just above the ankle, and a tall boot that's the length of a below knee cast, which is just below the knee. The recommendation for this procedure is a tall boot just below the knee. And the reason for that is the joint that we are fusing, realigning, and fixating is a midfoot joint. And in order to protect that correction and protect that joint, a tall boot is what is appropriate to dissipate the force as patients walk. What short boots are typically used for are for forefoot, or what we call toe surgery. But anything of the midfoot where this Lapiplasty is taking place, something we call the hindfoot back by the ankle, and then the lower leg, such as the ankle, we typically use a tall boot. So the Lapiplasty is a tall boot for 6 weeks that you can take off to bathe and sleep.
Okay. All right. Well, we talked a little bit about recovery, but some people are very specific with their questions in terms of thinking about their careers. We have someone who says, I work in a doctor's office, so I'm on my feet all day. Another question very similar is, I'm a nurse. How quickly could I return? And yet another one is, hey, I'm a single mom, I'm a hairdresser, I need to get back to work, and I'm on my feet a lot. So how would you address those type of professions and recovery?
Yeah, so all great questions. Some of those are patient dependent. Back in a shoe at 6 weeks, back to full activity 3 to 6 months. Those are the masses. However, everybody responds to surgery differently, and those are somewhat return to work or patient specific. How's the patient actually feel? Some patients will feel great at 2 weeks. Some people take 4 to 6 weeks to feel great. And so that's one of the variables that we can't predict. The other thing is you have to be in this boot, protected, weight bearing, and stabilizing the foot upwards of that 6 weeks. If your employer allows you to work in a boot, or you can work something out where you can take breaks if you need it, where the foot's swollen or just a little bit overuse and you need to rest it for a bit, those are again are patient specific. So if you can work that out, that certainly helps you. But for the most part, it's really patient dependent. If you're allowed to work in the boot and it doesn't bother you to do your normal job, whether that be nursing or single parenting or whatnot, you certainly can do that immediately. But again, I can't overstress this, that's patient dependent.
Okay. So one other question is, can I use stairs after surgery?
So that is a great question. Because we're so careful in regards to injuring or falling or whatnot, the patient certainly can use stairs from day one. What I typically recommend is the operative foot goes up or down the step last or second. So to try to illustrate that, if I had surgery on my right foot, I would step up with my left, bring my right foot or operative foot on the same step as my left, and then do the left foot again, and then bring up the right, left foot again, bring up the right, etc., etc. Now that may last for a week or two, upwards of 3. And then once you feel comfortable in the boot, walking end over end or foot over foot, you're certainly allowed to do that. But until you're comfortable with pain and stability, my recommendation is you go up one step at a time with the non-operative foot first. And
Okay. Some people have questions about, is it a loss of mobility when you actually have those plates fitted to that middle unstable joint?
Yeah, that is a tremendous question, and the answer is no. This joint and all joints of the foot and frankly the body have extensive anatomic and biomechanical testing that has been going on for years. And this specific midfoot joint is what is considered a non-essential joint. It's what we call a saddle bone joint. That means the two bones, the articulation of the two bones make the shape of a saddle where the two pieces fit together. And this joint has a relative motion of only a few degrees, 1, 2, 3 degrees. In fact, when this joint is fused where you realign the bones or the toe in a proper position, there are biomechanical studies that actually shows that gait improves, because patients that have this deformity of a bunion, as we've shown throughout the lecture, that joint is unstable. So once we stabilize the joint, your ambulation actually improves.
All right, we have some questions about hammertoes. Can a hammer toe be treated at the same time if you're getting your bunion treated with Lapiplasty? And then more specifically, would a hammer toe require it to be broken and realigned?
So,
or would it fix itself if the bunion is fixed?
Say that again, Kara. Sorry, the last part.
Or would a hammer toe fix itself if the bunion is fixed?
Yeah, so the hammer toe, just like a bunion, is a deformity, and they do not fix themselves. Once the deformity takes place, the same options that were for a bunion, wide toe box shoe, activity modification, these sorts of things, bracing or slings to help align the toe if they're not rigid, can be used. But if that doesn't work, your option is surgery. So to take the first part of that, yes, hammer toes can and routinely are fixed at the same setting. Any other what we call concomitant abnormalities or pathology of a forefoot or foot in general are addressed and corrected at the same time that the Lapiplasty procedure is. There are two main procedures to correct a hammer toe. One is what we call an arthroplasty, where we remove the joint of the toe that is deformed, and the other is called an arthrodesis, where we fuse the joint of the deformity. Both of these procedures are widely acceptable and have been done for decades, and it would be patient and surgeon dependent on which one would be offered to an individual patients. But the toe isn't technically broken. Either that joint is removed or that joint is fused in order to realign the toe.
Okay. So how do you address bone and bone at the joint? I was wondering if that means arthritis.
At the midfoot joint or at the big toe joint? Do we have that differentiation? I can talk about. Okay, I can talk about both. If there is arthritis of the midfoot joint where the Lapiplasty correction and fixation is performed, there is no problem with that. That is a joint that we are fusing anyway. And so if it is arthritic, that has no impact or bearing on the procedure and the outcome. That would be exactly the same, because we're already taking down that joint and fusing it. If there's arthritis of the big toe joint, and again, the cursor on the screen kind of shows that's where the toe moves up and down. If the arthritis is what we call moderate or severe, and severe being end stage, a lot of times that joint would be fused. And in patients, and again, this would have to be patient and surgeon specific, looking around specific x-rays in the foot. But if that joint has arthritis, the recommendation would be to fuse that joint. That means take that joint away and align the toe or fix the bunion with plates and screws, the same plates and screws, in order to eliminate the problem. But what that means is that big toe joint would not move. And I'm going to hold on. I'm going to kind of nip some of those questions in the bud right now. People will say, well, don't I need my big toe to walk, the motion of that toe? And when you have arthritis of that big toe, your motion is already eliminated. What has not been eliminated is the pain. And so what the surgery does is align the toe. The one specific case where Lapiplasty may not be appropriate. And again, that would be patient dependent and specific.
Okay. This is a good question. If it was your family member having the surgery, when selecting a doctor, how many procedures would you like them to have already performed?
If it was my family member, 4 million procedures. I'm just joking. That's a good question. And obviously experience counts and experience matters. Surgery is a trained skill. And so there are certainly surgeons that maybe perform procedures better than others, and it's no different than any profession, frankly. With that said, what this Lapiplasty system does, because it is a regimented system with reduction clamps, so to speak, cut guides, this is a procedure that allows tremendous reproducibility. And once a surgeon is trained, if they follow all the steps of the procedure and reduction appropriately, which that's what the training teaches them to do and allows them to do, the outcomes should be pretty similar, frankly. And again, experience matters, but if somebody has been doing Lapiplasty and they have the training, there wouldn't be a great reason to shy away from that specific surgeon.
Right. This question is, I am a 70-year-old female, type 1 diabetic. My last A1C was last week. It was 7.4. I really need this as I cannot wear any closed-toed shoes. Can I be a candidate?
Simply said yes. You know, diabetes is an autoimmune disease, and a lot of times if the blood sugar is too high, we worry about healing. The recommendation, and I'm not an endocrinologist, but the recommendation for hemoglobin A1C is somewhere around 6.5. And if you're at 7 or 7.4 for elective surgery, it is surgeon dependent on whether or not the patient can have the surgery at that level, or if they want a little tighter control. And one of the things we always also look at is the daily blood sugar or daily glucose. And if your daily glucose is around 126 milligrams per deciliter or lower, then again, you are a candidate for this procedure. So diabetes does not preclude you from having this surgery or correction. It would be the blood glucose control. So again, daily blood sugar of 126 milligrams per deciliter or less, and a hemoglobin A1C, and it's debatable for elective surgery, but anywhere from 6.5 to 7.5, upwards of even 8, patient dependent.
Okay, this is another very specific case study that I had multiple myeloma cancer and a bone marrow transplant in 2017. I'm in remission. My bunion has gotten worse on my left foot and started on my left foot. I've developed a very bad case of neuropathy from chemo. Will I be able to have the surgery?
So that's a great question. There are two issues with patients, that specific patient and patients in that unfortunate situation. One, because of the bone cancer and the transplant and whatnot, it'd be recommended to have a bone scan or a DEXA scan to test bone density. Because we're asking that joint to fuse, we want to make sure that the calcium and the mineralization of the bone is adequate in order to fuse that joint and take the pressure, so to speak, of the surgery. And that's something that we can work out medically as a surgical workup. The other potential issue is neuropathy. Neuropathy means that the feeling of your foot is less than normal. And patients sometimes don't have something called protective sensation. And when there isn't protective sensation of a foot and we do surgery on those patients with neuropathy, sometimes we have to have added fixation. So you certainly could still be a candidate for Lapiplasty, but in addition to the plates that we've shown, sometimes we would also insert additional screws around that correction in order to stabilize the joint or give it another layer of protection, just because you don't have the body's natural feedback of pain to help protect yourself. So again, that would need, that patient or patients in that scenario would need a specific individual workup.
Is the Lapiplasty procedure done as outpatient, and are you completely under during the procedure?
So yes, this is an outpatient procedure. Typically takes about 1 hour. You go home the same day. As far as anesthesia, that is surgeon specific. My patients, I prefer a general anesthesia. It's very safe. The patient's relaxed, and it just in my humble opinion, seems to go a little smoother. With that said, this could be done also under something called a MAC, which is a monitored anesthesia care, where you're getting medicine through an IV to kind of keep you sleepy, but you're breathing on your own without a tube in the back of your throat. So the two anesthetic choices are both widely acceptable for this procedure or most extremity surgery.
This person had bunion surgery on their right foot several years ago, and the bunion has returned. Would they be a possible candidate for a revision surgery?
Yes, the x-rays of the patient would have to be taken and a complete workup and evaluation. And as long as there's no arthritis of this big toe joint, then the procedure can be corrected as a revision surgery. And that is very commonly done with the Lapiplasty procedure. And the reason for that is the traditional osteotomy, as we showed previously in the lecture, is two-dimensional. And if that third dimension of frontal plane rotation isn't corrected, there's a high recurrence rate. And so that can be addressed as a revision, yes.
Is the Lapiplasty procedure considered to be cosmetic?
Yeah, so great question. Lapiplasty is not, any procedure you do for a bunion correction isn't technically cosmetic. The results are cosmetic, but not the actual procedure or the implants or that sort of thing. Patients typically have surgery for pain, and that is, I would say, 90+% of the time patients choose surgery. However, bunion surgery is different. There is a component of cosmesis or cosmetic results, and especially in young adults, there is a insecurity about the way their feet look. So in this specific deformity of a bunion, it is common that at times you can do the surgery for the cosmetic look of it because patients are embarrassed or a little self-conscious. So overall, we do surgery for pain and alignment. However, because bunions are so specific to the deformity, we can do it for cosmetic reasons as well.
So we have a couple of questions about the incision. How significant is the incision?
So that's a good question. You saw those scars in the earlier part of this lecture, and the incision is anywhere from 3.5 to 4 centimeters, and that's over the midfoot joint. Excuse me. And sometimes there's a small incision over the, and my pointer is showing it, over the outside of the big toe joint, and we use incision to release some of the deep tissue capsule that over the years of the deformity gets contracted. Those incisions heal very well. They're usually completely healed where the sutures come out within 10 days, upwards of 14. And then that scar, like any surgical incision, will dissipate over time. And again, you saw the pictures of the 12 and 16 weeks clinically, and that's what the typical incision looks like at that point.
Can I wear high heels again?
Yes. So because this big toe joint isn't altered, the normal range of motion of that joint is restored. And so once you're healed and the pain is not, you're not having pain of that midfoot, you can go back to a heel to the patient's tolerance. So yes.
Does the surgery take away the pain, and are you able to get in regular size shoes with comfort?
Yes. So with the anatomic 3D alignment, the foot is restored and the function is improved and the pain is dissipated. That is the entire goal of the surgery. As far as a normal shoe, the answer is yes. Because the bump or the deformity is reduced and no longer prominent on the inside, these shoes fit better.
This person says, I have inconsistent pain from my posterior tibial tendon. I also have a bunion on that same foot, my right foot. My podiatrist recommended Lapiplasty. Will this procedure relieve the pain in my posterior tibial tendon as well?
Yeah, so a lot of times the bunion is coupled with a flat foot. And, we're not sure why, we're not sure what comes first, the chicken or the egg, so to speak. If the flat foot radiographically and clinically is severe enough, then the recommendation would be to both at the same time, depending on the surgeon, fix the flat foot and have the Lapiplasty bunion correction at the same time. When patients have a flat foot or posterior tibial tendon dysfunction, the foot pronates or rolls in where the ankle kind of the arch collapses, so to speak. And if that deformity isn't corrected, even when you fix the bunion with a Lapiplasty, sometimes that force isn't dissipated enough. And again, that would have to be clinically worked up, patient specific with radiographs in order to have that conversation. But the Lapiplasty, as a general statement, will not correct the flat foot or posterior tibial tendon dysfunction.
Okay. So this person is curious, what is the level of pain for this surgery and how is pain managed?
That's a good question. I tell patients every day of my life, pain is subjective. What that means is 100 people can have the exact same surgery and the pain levels for all 100 people are different. Some people take no pain medicine. Most people take pain medicine for about 3 days. Some people need pain medicine upwards of 10 days or so. But that is patient specific and there's no way to predict that. But that is typically the what happens. How we manage pain is with rest, ice, elevation, the protected weight bearing in the boot. You can use anti-inflammatories with pain medicine, as we mentioned. But there's a comprehensive ways to treat pain. So we have narcotics, non-steroidal anti-inflammatories, ice, elevation, rest, protection, but pain is subjective, so it's hard to specifically answer that. But as I've said, typical discomfort lasts for only about 3 days.
Okay. This person says, I may require surgery to my right knee. Is it possible to have this surgery on my right foot within my recovery to knee surgery, trying to consolidate my time off of work?
Yeah, that's a good question, and it depends on the surgeon that would be doing the knee surgery. So a lot of times, if there are 2 surgeons involved, which almost always there is, because there's specific foot and ankle surgeons and specific knee, hip, etc. surgeons. Those 2 surgeons would communicate and work together, and they would come up with a plan. The reason I say that, and again, these are patient-specific conversations, however, just to try to give you an answer so you understand it. Once the knee is replaced for knee surgery, just like the Lapiplasty, the recovery is essentially immediate, and we want patients up and walking and getting back to recovery. When the Lapiplasty is performed, you're in the boot for 6 weeks, as we mentioned. And that boot is protecting the foot and, eliminating some of the natural biomechanics of the leg. And that boot may interrupt the natural recovery of the knee. And so again, that is a patient-specific conversation. However, sometimes the recoveries and the protective devices for the 2 procedures are different enough that they may or may not be able to be done within the same time frame.
We have a couple questions that are asking about comparison to other surgeries, like how does it compare to Lapidus? How does it compare to a microsurgery? Which would you like to flip to the last summary slide to just sort of walk through a comparison of Lapiplasty compared to a couple of the different procedures that are used?
Sure. I don't know if my computer froze or it's not.
Well, I can just ask you that. How does Lapiplasty compare to a Lapidus procedure?
Oh, I got it to move. Okay, so I'll go over these last 2 slides quickly, and I hope this kind of answers the questions. We can actually come back to this and we'll answer that specifically. So as you see this slide, there are 4 columns. There is the first column of the traditional 2-dimensional osteotomy. There's the minimally invasive osteotomy, the traditional Lapidus, and then in yellow highlighted is the Lapiplasty 3-dimensional bunion correction. And then the 4 subsets of this are which procedure corrects the deformity in all 3 planes, which procedure realigns the entire metatarsal, which procedure addresses the root cause of the bunion, an unstable joint, and which allows accelerated return or immediate weight bearing. And as you can see, the traditional Lapidus realigns the entire metatarsal and addresses the root cause. But what it doesn't do, which Lapiplasty does do, is it does not correct all 3 cardinal planes of the body, the frontal, sagittal, and transverse, and it does not typically allow immediate weight bearing. And that this little graph kind of depicts that fairly well.
Okay. And we did have somebody who said she'd had microsurgery done on one foot and was considering Lapiplasty on her second foot. So she was wondering how those would compare.
Well, you can see the depiction of the microsurgery versus the Lapiplasty. However, you know, it's a hard question, right? I mean, it's hard to compare the 2 feet. I don't know what your previous surgery looks like radiographically or clinically, but you know, we have a good idea what the Lapiplasty would look like radiographically and clinically, and I've showed multiple pictures that kind of show that. So certainly there is no reason why you couldn't have Lapiplasty on the other foot. And again, that's probably recommended.
There was a question about, can the incision be done more on the side of the foot versus the top of the foot?
Yeah, so that's a good question. This Lapiplasty procedure is a patented technique with specific instrumentation in order to get the reduction, maintain the reduction, and then fixate the joint. And that reproducibility and that instrumentation is designed specifically for a direct, what we call dorsal or on top of the foot incision. It cannot go more medially because then the cut guides and something called a fulcrum and the joint spacer and everything we use to assure that we have anatomic reduction and fixation cannot be used properly. So the incision, as you saw it, is what the procedure is.
Okay, this is a specific question. It says, will Lapiplasty take care of the bump on the top of my feet? My bunions are both level 5, but no pain in either foot. However, sometimes I have discomfort on the top of my feet if I'm on my feet a long time.
Yeah, the short answer is most likely. Again, those are radiographic and clinical evaluation. When the bunion deformity is present, there is an abnormal alignment, and that abnormal alignment created from instability causes the lesser toes and bones behind the toes to take abnormal pressure. And so a lot of times that abnormal pressure is at the ball of the foot, but that certainly can be translated into the top of the foot or the midfoot. A lot of times if patients are describing top of the foot or midfoot pain, they have arthritis through those joints. And again, that would have to be evaluated clinically and radiographically, and then options given in those specific cases. But that would not preclude you from having Lapiplasty. You could still have Lapiplasty if you have top of the foot or midfoot arthritis, and that would have to be evaluated.
Okay, one more question is, in addition to bunions, I have a collapsed metatarsal. Will Lapiplasty correct that?
So say that one more time, Kara, a collapsed metatarsal?
She says, in addition to a bunion, I have a collapsed metatarsal. Will Lapiplasty correct that?
Yeah. Unfortunately, the term collapsed metatarsal has multiple connotations. And so that specific patient would have to be seen, an x-ray would have to be taken, and I'd have to know specifically what that means, collapsed metatarsal. And I just don't know that from that description alone, unfortunately.
Okay. All right. Well, I'm going to give you one more question here. It says, what do you think about the Swiss compression technique to correct a bunion?
Did you say Swiss compression technique?
I did.
Like Swiss, like SWISS?
Yes, like Switzerland.
Okay. Yeah, I am unfamiliar with the Swiss compression technique. That is something I will certainly look up after this lecture and educate myself, but I am unfamiliar with that technique or term.
Nor am I. Okay, well, I want to kind of wrap up now. I really appreciate Dr. DeCarbo's time tonight. Really appreciate you all joining us. Just to reiterate, because there was several times this question was asked also, was do we have some specific data on recurrence rates for Lapiplasty? And we do have a published clinical trial data that states that 97% of bunion patients were able to maintain their 3D correction in a 13-month study. So that's a 3% recurrence rate. And so if your question did not get answered tonight, or you think of something later that you wish you'd ask, please feel free to shoot us an email at patientinfo@treace.net. We're happy to facilitate getting those questions answered, and you can also learn more at our patient website, which is called alignmytoe.com, and also find locally trained Lapiplasty doctors there as well. Can you remind us where you practice, Dr. DeCarbo? That was asked a couple times as well.
Yes, I practice in Pittsburgh, Pennsylvania, specifically at St. Clair Hospital in Pittsburgh. I am part of a group called St. Clair Orthopedic Associates, and we have a website where I can be found with a simple Google search, or the website is stclairortho.org. So that is how I can be contacted.
Okay. And as a follow-up to this evening's presentation, we're going to be emailing all of the registrants an archived webinar link for reference, so be on the lookout from that for us. And then we hope you had a great time. We had a lot of nice comments thanking you for your presentation tonight, Dr. DeCarbo. I hope everybody has a nice evening.
Well, thank you, and thank you for sharing this time with me. Again, those were very appropriate questions, and if any patients want in contact with myself or any trained Lapiplasty surgeons, I encourage you to take the next step. This is a great step you took already, but I would encourage you to take the next step and actually get evaluated radiographically and have the discussion around your specific deformity, and then you'll proceed accordingly as you wish.
Thanks, everybody. Good night.
Bye now.